हेलो, गुड इवनिंग, नमस्ते, खुशामदीद। मैं आपकी होस्ट और दोस्त डॉक्टर विनी कांट्रू। मैं एक पल्मोनोलॉजिस्ट और क्रिटिकल केयर फिजिशियन हूँ इंद्रप्रस्थ अपोलो हॉस्पिटल्स, नई दिल्ली में। मैं आपके सामने फिर से एक एपिसोड लेकर आई हूँ डॉक्टर केके's मेड टॉक्स का। टुडे वी आर गोइंग टू डिस्कस about a very very important but neglected topics for which we have a special guest. More about that later. उसके बारे में कुछ देर के बाद। लेकिन अब हम चलते हैं हमारे 819th एपिसोड के हेडलाइंस ऑफ द डे पे। So, what are the headlines for today? The Indian Medical Association opposes any proposal on teaching Ayurveda to MBBS students. If we are teaching Ayurveda to MBBS students, then it is going to be a mixture of two of the important sciences. We cannot negate the importance of both the sciences, but they should not be mixed together. If somebody wants to study Ayurveda, they can do it separately as opposed to the MBBS, which involves the study of medicine, and the allopathy, which is related to treating many kinds of diseases. Australia has to expand the rollout of the fifth COVID vaccine shot. We have all seen there are so many available vaccines now in the kitty against COVID 19, and every nation is coming up with a newer kind of vaccine which is acting in some other way. This is a good news because it is going to increase the armamentarium against this kind of disease, which is COVID 19, which has played havoc throughout the world. Study has revealed that there have been no new variants in the weeks following China ended its zero COVID policy. We all know we were scared. The number of cases in China was very, very high, and we were thinking another kind of variant shouldn't come into the picture, which is just making our life miserable again. हमें इस बात की खुशी है कि चाइना की सर्ज जो कोविड 19 की देखी गई थी, उनकी जीरो कोविड पॉलिसी को एंड करने के बाद उसके बाद देखा गया है कि कोई ऐसा नया वेरिएंट जो वेरिएंट ऑफ कंसर्न हो नहीं पाया गया है। ये एक खुशीजनक बात है। इंडियन कैंसर सोसाइटी लॉन्चेस मंथ लॉन्ग कैंसर अवेयरनेस कैंपेन। जो इंडियन कैंसर सोसाइटी है वो इस पूरे महीने कैंसर अवेयरनेस प्रोग्राम्स कर रही है, क्योंकि इसी से हम लोगों में कैंसर की जानकारी बढ़ाते हैं। The study revealed that artificial intelligence to detect effectiveness of breast cancer chemotherapy can be very, very useful. हमने देखा है आर्टिफिशियल इंटेलिजेंस किस तरह अपने पांव फैला रहा है हर किसी फील्ड में, इंक्लूडिंग दैट ऑफ मेडिसिन। तो ये जो है इसका अर्ली डिटेक्शन ऑफ कैंसर्स के लिए भी यूज हो रहा है। उसमें देखा गया है, जब एक स्टडी की गई कि जो ब्रेस्ट कैंसर है उसे किस तरीके से हम जल्दी डिटेक्ट करें, उसमें काफी यूजफुल साबित हो रही है। चलते हैं बहुत जल्द अपने टॉपिक ऑफ द डे पे। हमारा आज का टॉपिक बहुत ही ज़रूरी और नेग्लेक्टेड टॉपिक है। वो है जीरियाट्रिक डिप्रेशन, यानी कि ओल्ड एज में डिप्रेशन का होना। इसके लिए हमारे साथ हमारे नए गेस्ट हैं आज, जिनको मैं इंट्रोड्यूस करना चाहूंगी। आई वुड लाइक टू इंट्रोड्यूस डॉक्टर देबांजन बैनर्जी। हाय। हाय, you're mute, Dr. Debanjan.
Yeah, am I audible now?
Yes,
Yeah,
you're very well audible now. Thank you so much for connecting to us.
thank you, Dr. Kantru, and thanks the Meditox team, and a warm welcome to our audience today. Very good evening.
Let me tell you about Dr. Debanjan Banerjee. He has completed his post graduation in psychiatry and postdoctoral in geriatric psychiatry from the esteemed National Institute of Mental Health and Neurosciences, which is the NIMHANS, Bangalore. He has been in the Department of Psychiatry, NIMHANS, for nearly a decade and headed the Student Welfare Committee there. Currently, he is affiliated with the Apollo Gleneagles Multi Speciality Hospitals, Kolkata, as a consultant neuropsychiatrist and is the founder of Arogyam, a mental well being polyclinic in West Bengal. Dr. Banerjee is the recipient of several prestigious awards, including and has held several important national and international memberships. He is the convener, Early Career Psychiatry Section, SARC Psychiatric Federation, and he acts as the deputy editor in chief, Journal of Psychosexual Health, and associate editor, Journal of Alzheimer's Disease, and assistant editor, IPA Bulletin. Besides his clinical acumen, he is internationally known academician and researcher and has over whopping 110 peer-reviewed publications and is a regular columnist for several Indian dailies. He also works with data leads and Google News initiatives as an executive fact checker for fighting medical misinformation and promoting community awareness related to mental health. So much to your kitty, Dr. Banerjee. It's so much of degrees, so much of knowledge, and helping out with the mental health. It's really, really commendable.
Thank you for the kind introduction, Dr. Kantru. I think mental health is some place in our country जहाँ पे हम अभी तक सही तरीके से शायद लोगों तक पहुँचे नहीं, but we are trying our level best, to raise the awareness, and it's shows like this, and thanks to the organizers, thanks to you, we can reach out to more and more people about such important topics. So thank you once
Yes,
again for having me here.
definitely. You're most welcome, and thank you for sparing your precious, precious time. So, we have known depression in many forms. It comes in any age. We all know it can be present in childhood, which is an age of enjoyment. However, it can be seen in very young people, in middle age group, as well as in older people. We have all seen that we might be ignoring signs of depression in the elderly population. So, first of all, let us know what is geriatric depression. ये geriatric depression क्या होता है?
Yeah, as you rightly said, Dr. Kantru, I think depression, firstly we have to understand, और मैं ये सभी के लिए बताना चाहता हूँ कि सिर्फ खराब लगना या मन खराब होना डिप्रेशन नहीं होता है. There is a difference between sadness and depression. So we all feel sad at different times. If I do not have a good experience, मुझे एक दिन अच्छा नहीं गया, कोई जॉब में प्रॉब्लम हो या किसी के साथ कोई पर्सनल इश्यूज हो, तो क्वाइट नेचुरली मुझे खराब लगेगा. बट इफ दैट कंटिन्यूज फॉर अ लॉन्ग टाइम, उसके साथ अगर नींद के तकलीफ होने लगे, भूख कम हो जाए, वेट कम हो जाए, you continuously start feeling hopeless, negative about yourself, you start having wishes that it's better not living, then probably it is a diagnosed depression, clinical depression. जैसे आप पल्मोनोलॉजिस्ट हो, जैसे ट्यूबरक्लोसिस, कोविड या कोई इन्फेक्शन, डायबिटीज, प्रेशर, हाइपरटेंशन जैसे ये बीमारी है, वैसे क्लिनिकल डिप्रेशन भी एक बीमारी है जिसका ट्रीटमेंट होता है. हैविंग सेड दैट, एज यू राइटली सेड, कि यह हर उम्र में हो सकता है और इसमें हर अलग अलग टाइप का लक्षण होते हैं. जीरियाट्रिक डिप्रेशन या ओल्ड एज डिप्रेशन एक्चुअली काफ़ी कॉमन है. तो इंडियन डेटा के हिसाब से roughly 1 in every 5 individuals above 60 years, 60 के ऊपर में जिनके उम्र है, सीनियर सिटीजन्स, हर 5 में से करीब 1 या 2 में ऐसे डिप्रेशन का लक्षण दिखाई देता है. एंड इट इज़ अ लिटिल बिट डिफरेंट फ्रॉम व्हाट वी फील. So, they will not directly mention about feeling sad or feeling low. Rather, physical symptoms ज़्यादा होने लगेंगे. जिनका पहले से दर्द है, पेन का प्रॉब्लम है, काफ़ी कॉमन है बुजुर्गों में कि घुटनों का दर्द या हाथ पैर का दर्द, गर्दन का दर्द, वो बढ़ने लगेंगे. They start getting very, very preoccupied about their own health. Many people come to us just telling, doc, that I am not having proper bowel habits. I feel that something is wrong with my body. I am not feeling all right. But if you ask them, how is your mood? They won't tell you that you are feeling low, which is the common sign of depression. So that is why it is very easily missed. वो क्लिनिक्स में मिस हो जाता है तो हम ट्रीटमेंट नहीं कर पाते हैं. सो आई थिंक दैट्स अ वेरी इंपॉर्टेंट थिंग टू रिमेंबर. ऑल्सो अगर किसी को शुगर है तो यू कैन सी द डायबिटीज इज इंक्रीजिंग, द शुगर लेवल्स आर हाई, प्रेशर बढ़ जा सकता है, the BP can fluctuate more and more. Many times they feel very lonely. They may just come and tell you that, I think my life has gone enough and I just don't feel like living anymore. And very importantly, जो गैस्ट्रोइंटेस्टिनल सिस्टम होता है, जो डाइजेशन का प्रॉब्लम्स होते हैं, गैस्ट्राइटिस का इश्यूज होते हैं, वो काफ़ी हद तक बढ़ जा सकते हैं. एंड स्लीप इज़ अ मेजर प्रॉब्लम. एंड एंग्जाइटी, लास्टली आई वुड लाइक टू मेंशन एंग्जाइटी. काफ़ी जिटरी हो जाते हैं, रेस्टलेस, एक जगह पे बैठ नहीं सकना, एक हमेशा सा एक लगना कि कुछ ना कुछ लग रहा है, मुझे रेस्ट में नहीं लग रहा है, मुझे चलना चाहिए, कहीं पे बाहर जाना चाहिए, हर चीज़ में एक डर रह जाना. आई थिंक दीज आर very common symptoms of depression in old age that we need to keep in mind.
All right. So we have many people who are connected to us. Gauri Shankar Dharmraj ji has asked a question which I would like to take up later. But he is from Chennai, so most of the time he's requesting that we speak in English because they don't know Hindi much. We would try our level best that we are translating some of the important sentences in Hindi also. So we have seen that what is geriatric depression and how common is this disease in the elderly. And one important message which has come out of this first question is that we should not be, kind of masking these symptoms with the fear that we may be judged based on our symptoms that we are having depression. Look, you are so much in age and still you have not been able to cope up. ऐसा नहीं होना चाहिए, क्योंकि जैसे डॉक्टर बैनर्जी हमें बता रहे हैं कि डिप्रेशन भी एक डिजीज ही है, जिस तरीके से बाकी डिजीजेस होती हैं, ये भी एक डिजीज है और ये ट्रीटेबल है. यदि आप ये सोचते रहेंगे कि बाकी लोग क्या सोचेंगे, तो प्लीज इसको सोचना बंद कर दीजिए, क्योंकि एक फुलफिलिंग लाइफ जीने के लिए ये बहुत जरूरी है कि आपकी अंडरलाइंग कंडीशन को डिटेक्ट किया जाए और उसको ट्रीट किया जाए. वेरी वेरी इंपॉर्टेंट to detect your underlying condition and get it treated. So, if we talk of geriatric depression, how is it different from the depression which is suffered by people in other age groups? किस तरीके से हम देखते हैं कि बाकी एज ग्रुप से ये अलग डिप्रेशन है? क्या कुछ ऐसे साइंस हैं whereby the symptoms are masked and people don't come forward, or there are some other signs and symptoms which are present in this particular age group? Kindly unmute yourself.
I think spontaneous getting muted. Yeah, sorry. So thank you, Dr. Kanstruji. I think as you rightly said in the beginning, every age has its own takes in terms of depression. And old age specifically has many social and physical factors. Let's take the physical factors. There are a number of medical illnesses that come in. Most of us, who see patients above 60 years, they come with a host of other medical conditions, जैसे कि diabetes, hypertension, thyroid, prostate का problem, postmenopausal issues in women. So all these factors, the up and down of the hormones, age, frailty, जिनको हम बोलते हैं, with a, gradually as the age progresses, all of them have a bearing on the mind, a bearing on the mood and depression. Number of social factors exist, particularly after COVID-19 scenario. Many seniors are separated from their children. What we call as an empty nest phenomena. That, abhi with time, a lot of family is nuclear. So parents are here, probably the children are somewhere else. They only can barely connect with them digitally. Sorry, I'm very sorry. Sorry. So many of them are living alone and probably are also living separately from their spouses. The other factor is, there are two types of senior citizens. One who live at their homes, one who live in old age homes or senior citizen assisted care facilities. So for them, there are other challenges as well. Now, these factors also have a bearing on depression. Finally, as you asked, how is it different? लास्ट क्वेश्चन में मैंने मेंशन किया था कि सिम्टम के हिसाब से अगर आप किसी से पूछे कि इफ यू आर फीलिंग लो, इफ यू आर फीलिंग सैड, in old age people may not tell you that, rather they will be more focused on their bodily problems. So that is why many times in old age people do not really come to us for the first time. They go to our medicine colleagues, or they go to our geriatrician colleagues with those problems, and then they probably get referred to us. Sleep is a major issue. Anxiety is a major issue. हर चीज में एक डर बैठ जाना, sometimes having unnecessary fear, which we call as delusion, that probably somebody is following them, somebody will do something to them, suspiciousness, शक होना किसी के ऊपर, that is very common. The other thing, if we talk about signs, I think a lot of pathology of depression, कि जैसे वो होता है, जो जो changes होता है दिमाग में, they are little bit synonymous with dementia, or when we tell, Alzheimer's disease. Certain parts of the brain which are affected in memory, which are affected in terms of which slows down your thinking, which slows down your movements, those parts are affected in geriatric depression. इसलिए काफी टाइम पे जब लोगों को स्ट्रोक होता है, if anybody suffers from a stroke, after that we can actually find signs of depression in them, because blood clots, even if they're small blood clots, somebody who has high blood pressure has a risk of this. Tiny blood clots throughout the brain over a period of time have the risk of producing this geriatric depression. So a type of geriatric depression is also called as post-stroke depression or vascular depression, जो कि stroke के बाद normally 60-65 years के बाद होना बहुत common है. So as we can see, there are a lot of different associated factors, lot of physical illness related factors, social factors, और जिस तरीके से डिप्रेशन होता है और जिस तरीके से वो मैनिफेस्ट करता है इंसान में, वो काफी अलग है. सो द चांस ऑफ मिसिंग आउट, द चांस ऑफ probably not getting treated is also very high. And as you beautifully mentioned, stigma is also very very high. Normally अगर हम किसी को सुनते हैं तो हम बोलते हैं ठीक है, आप तो इतना कुछ एक्सपीरियंस कर लिए, you can also cope with this. But depression is an illness and it needs treatment. You cannot just cope up with depression.
Definitely so. So, if you're suffering from any of these symptoms which we just spoke about, please go and get yourself checked by a psychiatrist, especially who is trained in geriatric medicine, like our doctor, Dr. Banerjee. So, we need to be very, very quick in, taking out these symptoms and taking out the fear of discussing these symptoms with your doctor, because once there is fear of discussing your symptoms with the doctor, you will not be very very clear and forthcoming about your problems. And also, I think we should discuss that how a family can help detect the early signs and symptoms of depression in the elderly. We as children, we all face it. Our parents are getting aged. They might be having certain kind of problems, health related issue. So how can children and close family members help their parents and their relatives who may be suffering from depression? Are there any early signs and symptoms where a child or the family member should think of getting their parents checked from a psychiatrist?
Yeah, I think that's a very, very relevant question, Dr. Kantru. Thank you. If we are able to detect it early, we'll be able to treat early, and that saves a lot of suffering. So I think there are few common signs, nothing pretty out of the blue, but we need to keep a watch on their usual behavior. अगर हम किसी को देखें कि वो अपने बिहेवियर से कुछ अलग ही तरीके से बिहेव कर रहा है, जैसे बहुत इंट्रोवर्ट हो गया है, द पर्सन इज बिकमिंग सोशली वेरी आइसोलेटेड, नॉट इंटरैक्टिंग मच विथ पीपल, is extremely preoccupied with his or her physical symptoms. Let's say he or she has a stomach pain or a small infection, but even after that becomes better, they keep on telling about it and they cannot focus beyond it. uh, One very, very important factor in old age depression is memory. And memory doesn't mean simply forgetting. They may start misplacing things, problems in multitasking. They may not remember something which you have told them. They may forget probably something I've told in the morning, they may tend to forget it in the afternoon. uh, जैसे ख्याल नहीं रखना, you tell 3 4 things and they easily tend to miss out on one or two. Somebody goes to the shop and then misses out on a list. You give them 4 5 tasks in a sequence and they tend to miss out one after the other. So if it happens in the context of a stressful factor, because another factor in old age is loss. Many people lose their spouses, lose their family members. Sometimes a big factor which we often neglect, I'm sorry I forgot to mention, is retirement. So imagine somebody who has been financially independent, head of the family. One fine day, the job is not there, and many times they have to rely on the other person for their financial independence. Their social circle gets limited. So this autonomy, this freedom, ये जो एक बंदा हमेशा से स्वतंत्र रहा है, independent रहा है, and one fine day after retirement, the person suddenly feels that I do not have any work to do. So how do I participate in society meaningfully? I think that creates a big vacuum. I do not intend to say that retirement brings depression. Retirement brings in a fantastic phase of life where you can go back to enjoying yourself. But it definitely, in some individuals, create that sense of vacuum which leads to the risk of depression. Now, if you see somebody very overtly introvert, sudden change of behavior, lacking sleep, losing weight, food suddenly has developed certain changes in food preference, memory issues, is become quite irritable. बहुत छोटे छोटे बात पे गुस्सा हो जाता है जो कि उनका प्रीवियस बिहेवियर जैसा नहीं है. I think these are very common signs to identify that somebody is probably going into clinical depression. Not to mention, there are certain red flag signs, certain emergency signs जिनको हम बोलते हैं. अगर बहुत ज्यादा weight loss हुआ, अगर एकदम खाना छोड़ दिए, अगर एकदम घर से बाहर नहीं निकलते, they are totally isolating themselves, and especially if they have expressed suicidality, if they have expressed that they don't want to live anymore. मैं कभी it comes indirectly sometimes कि शायद अगर हम नहीं रहते तो अच्छा होता, in a passive way. But that is very, very important to identify, because suicide rate in old age depression is very high. And especially in our family setting, many times we are not able to monitor them. And if they try, if by chance, unfortunately, there is an attempt, the chance to revive them is very, very less. So we have to prevent it at any cost.
Very, very right. Because in elderly people, the level of recovery which happens is less because their systems are not very, very robust. So, if they try at suicidal attempts and damage any kind of their body systems or organ systems, for them it becomes very, very difficult to be revived and getting better to their basic self, which is very difficult as compared to detecting the problem early. So let's come to the next question. Are the symptoms similar to any other kind of medical illness? Is there a difference between depression in old age, or there are some differential diagnoses which should be kept in mind and which should be important for us clinicians who see elderly people in our clinic with some other medical related issues? So, when can we as clinicians send you the patients after ruling out certain conditions? Let's discuss that.
Yeah, I think that is very important when we have a cross-disciplinary discussion, especially that you are a critical care expert and pulmonologist. I think one of the very common area where this intersects is obstructive sleep apnea and obesity. So especially, we get a lot of individuals who suddenly come and tell us that I'm feeling excessively drowsy, excessively fatigued throughout the day. And then we come to know probably they are using CPAP or they are not regularly using CPAP. They have a diagnosed OSA. So what I intend to say is that because old age depression involves a lot of physical symptoms. Most of the times, these individuals, and because of the stigma towards psychiatry, they may actually end up going to all our medical colleagues of different fields. And if you feel that you know this, definitely you can conduct your own array of tests or investigate on your own partake. But if you feel that this has a basis of stress, or this has a temporal relationship with a particular incident in his or her life, obviously that's an indicator. I think a very, very important factor here is every single non communicable chronic illness has a bearing on depression, and it's mutual. So, diabetes, hypertension, osteoarthritis, rheumatoid arthritis, any connective tissue disorders, inflammatory bowel disease, uh, any kind of infection. Now that post COVID, long COVID, we have seen a lot of increase in depression and anxiety cases, particularly if you have prescribed steroids to any individuals for the first time, and the individual has a history of psychosis or depression in the past, I think it becomes very important to keep our antenna raised. Especially, I think depression is almost an inevitable accompaniment of untreated diabetes, rheumatoid arthritis, lupus, obstructive sleep apnea, chronic obstructive pulmonary disease, and especially a very, very important field of psycho-oncology, cancers, because there is a lot of social factors involved, HIV. So these are things which intersect continuously. But one most important thing would be dementia. So a lot of our neurology colleagues, they get this individuals with forgetfulness, even we get, and in our neurocognitive clinic. So the individual may not come to you or come to us with any psychiatric complaints at all. The family member may just begin telling, this person has forgotten way or has started forgotten words. But this particular feature, as we all know, is very well known phenomena of pseudo dementia. And in old age, depression can actually be a harbinger of dementia. So many times the person presents with depression gets treated and then gradually progresses to a mild Alzheimer's variant, or somebody who already has dementia, that person may feel shy about it, feel worried about it, that I'm not able to probably do like others, I'm not able to remember things like others, I'm not able to meaningfully participate with others, and thus develop depression. So I would like to put it in two ways. Every individual who has a sudden onset memory loss in old age on the background of some other factors, social factors, chronic illness, let's keep our antenna raised for late life depression or geriatric depression. On the other hand, if somebody develops dementia, the person is not immune to depression. So, of course, at that point of time, if there is a sudden worsening of memory, sudden change in sleep cycle, sudden change in eating and dietary patterns, and weight loss, again, we have to keep our antenna raised for depression, because it's a very, very common comorbidity. Also, Parkinson's, a very, very common accompaniment with Parkinson's disease.
Yes, very well said. All these symptoms, signs, diseases are very well connected with depression. And as you said, the plethora of non communicable diseases in this age group per se somehow leads to some amount of depression in this age, including less physical ability and mobility, which is known in these kind of people and age group. When their mobility decreases, they do get bouts of depression, which should be taken care of. Let's look at the people who are connected with us. I would like to welcome and thank Dr. N.S. Sharda, who connects to us every Wednesday. Thank you, Dr. N.S. Sharda. Vikas Sanyal ji is there. Swapna Jain is there. Good evening, Rameshwar Singh Panwarji. Kaushik Chakrabarti, thank you so much for connecting. Ganesh Ambhore, Satendra Singh, Gauri Shankar Dharmraj. I hope we have been able to discuss things in English and you are following the discussion very well. And let me take up your question, which is there for Dr. Banerjee. He wants to know that diabetic depression is common, as you already described. So, Other than counseling, are there any medications for diabetic depression?
Yeah, thank you for the question. Before answering that, I'd just like to take one point from the last question. The thing which I probably missed and is very important is pain. So a lot of older individuals, senior citizens, they suffer from different types of pain, including osteoarthritis, uric acid related problems, gout, different types of other types of arthritis. So one of the very common indicators of depression is a sudden unexplained increase in pain and lowering of pain threshold. So that gives us an important clue. Coming to your present question, of course, we do not term it separately as diabetic depression, but yes, any depression with diabetes, it is mutual. So the depression will increase the sugar levels, and the increased sugar levels can be an indicator of depression. And many times, we do not even need to change the medicines of diabetes. We treat the depression and the sugars normalize on their own because both of them are related to a common pathology. So, yes, I should highlight this factor that depression in old age can be fully treated. And antidepressants that we prescribe, there are standard antidepressants which are used in old age at a standard dose. But you have to remember that it is always better to discuss the treatment that the doctor is giving you with the doctor as to what effects can you expect, when can you expect, how long do you need to take the medicines, what side effects can you expect, because if these discussions do not happen, if you just stop taking it after 3 days 4 days, there will be no effects. Unfortunately, our medicines, like any other chronic illness, uh, they need to be continued at least for 4 to 6 weeks for effects to even start appearing. They're not like paracetamol or an analgesic that you take and within 6 hours your pain vanishes. So you need to probably be a little bit patient, and the medicines start working within 2 weeks, start taking full effects within 4 weeks, and then you need to continue it up to a certain course as your doctor suggests. So having this discussion, this dialogue with your treating doctor, and trust me, all of us are sitting there to explain things to you. So nobody will reject your questions, but make sure that these discussions happen possibly right in time before you start your treatment. And along with that, there are different types of psychotherapies. Counseling is probably not the right word because it's a very generic term. So psychotherapies are one-to-one sessions with a qualified clinical psychologist which targets specific symptom domains and has certain specific approaches. It needs at least, depending on the condition, 6 to 10 sessions, which are held once a week or once in 2 weeks. And the most common, many of you must have heard about cognitive behavior therapy, because our thoughts, the negative thoughts that come in depression, that kind of lead to how we act and behave. So the therapy is targeted to modify the thinking patterns so that it also reflects on our behavior. But as we have to understand, medicines and therapy, they are not supplementary to each other, but they are complementary. So they are not replacement of one another. The best effect always happens when both are combined. So always have that discussed with your doctor.
Right, that is the best way of describing it all. We have Sartaj Singh ji associated with us, Avat Kishore Rathore ji, namaskar to you also. We have Vinayak Sharma, good evening to you, Rekha Batara, uh, Dr. N.S. Sharda, who was actually mentioning financial problems as an important factor, which we already discussed. Rameshwar Singh Panwarji has a question which I would like to take. He says his wife, who is aged 68 years, as a patient of thyroid and taking 125 microgram of thyroid supplement, is always feeling depressed. What is your expert advice?
Yeah, thank you again for this question. I think again there are certain things we need to know, whether when was the last thyroid test done, whether uh, the supplement is adequate for her, because if it is too much or too less, both the times hypothyroidism and hyperthyroidism can be linked to depression. uh, if there is a recent change of dose, that can contribute to some depressive symptoms, particularly in patients with hypothyroidism. There is a lot of fatigue, there is a lot of tiredness, and that itself is a symptom that coincides with depression. So if she is feeling depressed all the time, I think it's better to get her evaluated by a psychiatrist, and we need to understand if a clinical depression has set in, then probably along with adjusting the medicine of the thyroid supplement dose, we also separately need to treat her with antidepressants. I think that will be the best way to go. And also please check if the sleep is adequate, because one important thing in older people, they tend to sleep more during the daytime. So increase sleep during the daytime or phase shift, so sleeping late and waking up late, that is distinctly associated with depression in older people. So the more you spend time in bed in daytime, the more probably is the risk of you getting depressed or increasing the depression if it is already there.
Right. So, another question, we have seen that many people have the fear of taking medication out of the fear of side effects. So, this happens with any and every kind of allopathic medicine, and we see it every day, day in and day out, especially so with antidepressants. So, people are very, very fearful of taking these medications out of the fear of side effects. On similar question lines, Satendra Singh has a very valid question. So, one part of the question is, what are the most common side effects, and when should we start off immediately seeing our doctor if these kind of symptoms are developing? And the second part of the question is that, are these medications lifelong, or any particular duration they can be taken, and later on, once we are treated, we can think of stopping these medications?
So thank you so much for the questions. I think these are the questions that we face commonly in our clinics. Like every person, after we prescribe them, they leave, and before that, they ask these questions to us. So to answer the first question, I always tell my patients this: that you take water or you take any type of food, it has an effect, it has a side effect. Anything that enters your body, be it allopathy, homeopathy, Ayurveda, any form of medication, food, water, it will have both effect and side effects. Most of the times we are able to see the effects, we are not able to see the side effects. The problem with searching for them online is Google will give you 100 side effects of every medicine, but Google will not tell you that out of that, the top two is faced only by probably 2% of the population, which means that you are likely not even to face any of them. So, what I intend to say is that every individual reacts differently to every medicine. There are certain people who are allergic even to paracetamol. So it is always better that whichever medicine is being prescribed to you, as I mentioned, you sit with your doctor, spend 5 minutes, ask him or her three things. One, when can I expect the effect of this medicine? What side effects can I expect from this medicine? If the side effects happen, what should I do? Should I reduce the dose? Should I call you? Should I take any other substitute? And how long should I continue this medicine? I need to be clear with something at the beginning. None of the psychiatric medicines are addictive. It is same as any other allopathic medicines. Our medicines are not exotic. They don't come from a different planet. So it's all about the non-communicable diseases, the chronic illnesses. Like in antibiotic course, you have 5 days, 7 days, 14 days. We do not have such a short period of time. Let's say, like Dr. Kantruji, your field, somebody has asthma. So, sometimes you need to take the inhaler for a long period of time, sometimes lifetime. And if it is only seasonal, then you need to take when and where the problems start. So similarly, when we give antidepressants, let's say we are talking about old age depression here, we first give a course for 3 to 6 months at an optimum dose. Now, if you have any side effects, the common side effects of it varies between the different classes of medicine. Mostly it can be a bit of gastritis, nausea, problems with digestion, more of sleep, sometimes nightmares, sometimes a bit of increase in anxiety, constipation. These are the common ones. Now, if you face this, I think it's very important that you discuss with your treating physician, but mostly it is self-limiting and the body will take care of it within 1 or 2 weeks. So you don't need to worry. But if you face them persistently, obviously your doctor will change the medicines based on which medicine suits you best. So there is no one rule that one medicine is fit for one person. It's always a trial and error method. So it's always better to have continued discussion with your treating psychiatrist. And as to how long you need to take, if the first episode of depression happens, the rule is you usually take for 6 months. Then your doctor starts reducing the dose gradually. It's not that one fine day snap you stop the medicine, because then problems start appearing again. Like there is a way to start, there is a way to stop. Best left to the doctor to decide that. So you talk to him or her and you start reducing the medicine gradually. They will warn you that, okay, if while reducing the medicine you have some side effects coming up, then, or you again start having depression coming up, then probably you come to me, or you do not stop there, you continue the medicine, something like that. Let's say you have stopped the medicine for, let's say, 20 to 30 people in every 100 people, they will probably not have another episode. But if you have another episode of depression for any reason, that is more than one episode, it is better that you continue for at least 2 to 5 years. And for some people who have repeated episodes, if they are stopping medicine, it needs to be continued lifelong. The proportion varies, the rate of response varies, how long you need to take medicine varies from every individual to individual.
Right. Very pertinent question from Ali Nazakat, who's connected to us. He says, are there sometimes features of attention seeking syndrome in elderly and how to deal with it?
Yeah, so thank you for the question. I think we have first have to understand what is attention seeking. Now, let's say somebody lives alone, and somebody's probably doesn't have a proper social support, or the children live far away, or they probably live in a distance and they are not regularly in communication because of different logistic reasons. So it's natural for anybody to seek attention in that case. I don't think attention seeking can be considered abnormal or pathological in such circumstances. However, sometimes, as I mentioned, in depression, there is a lot of tendency to self monitor or self observe symptoms. So then they can repeatedly come to the family members and tell that, look, this is going wrong. Look, you have given me the medicine, but still pain is not going down. Look, constipation is not getting cleared up. I'm still not passing motion properly. Look, still the urine is this kind of in color. So there can be many kind of this preoccupation with the physical attributes, and that can be a form of attention seeking, because doctor shopping or recurrent doctor visits is also an indicator that a person is probably suffering from anxiety and depression in old age.
Right. We have one very unique question, and it is from Rukmini Rana. She wants to know, going to washroom too frequently, is that a sign of depression in old age?
Not really. It may be, of course, probably the first thing we would suspect, if it is in a male individual, probably if it is due to prostate problems. Very commonly in both the genders, it can be due to urine infection. For individuals, for ladies, it can be postmenopausal. But I think, again, as I mentioned, if the other fields, if medical specialties have already evaluated and nothing has been found, and the individual repeatedly goes to the bathroom and probably doesn't urinate, and then comes back every time and then still tells that, okay, the person has to go repeatedly without any apparent reason, then maybe we need to suspect that it can happen due to stress and it's not happening due to a medical illness. I need to clarify here that not everything that cannot be explained by medical causes is depression. But at the same time, if our medicine colleagues have evaluated somebody and nothing has been found, an opinion from the psychiatrist is taken to understand if there is any other underlying cause or stress related cause, because sometimes it stays invisible.
Right. Anand Ambaliji wants to know the role of ECT in depression among the elderly. What are the precautions which need to be taken?
Oh, thank you, Dr. Anand. I think that's a beautiful question, and I was almost about to say it. Uh, ECT or electroconvulsive therapy. I know many of you have seen it in movies and have read about it and scared about it, but let me be very clear: ECT is a wonder treatment. It we back there at Nimhans, we used to administer roughly 30 to 40 patients each day, and whatever is depicted in movies or shown commonly that creates this panic among people is totally not right. Long back, it was probably given forcefully, but now the practice of ECT is extremely scientific, civilized, and it's done with the presence of a psychiatrist and anesthetist under proper anesthesia. Only a very brief amount of current is passed to the brain in a controlled procedure, and it has scientific evidence that it can serve as life saving in individuals who are suicidal. In fact, it is one of the treatment with minimum amount of side effects. The side effects which you take once medicines come in your system even are not there. And some individuals who do not respond to medicines, even they start responding after a course of ECT is given. For any further information, if any of you are interested in reading, I had written something on Telegraph on ECT. Please, you can Google it. It is freely available. Also, you can go to the Nimhans website and check on the ECT information manual for the caregivers. It beautifully explains the role of ECT in depression. Also, back there at Nimhans, we ourselves had done a short movie and educational short film which our students had acted in. I had scripted it, and one of our other consultants, Dr. Preeti Sinha, had directed it. It is freely available on YouTube. For any of you interested, please Google electroconvulsive therapy, rekindling hopes and busting myths, and type Nimhans, and you will get it. It has both versions, a 40-minute version and a 15-minute version, and it will basically give you the entire answers to how ECT, how effective ECT is in depression, particularly in old age.
Right. Thank you for that information, Dr. Banerjee. I think some of the questions are repetitions of what we have already discussed. I would suggest all our attendees today to go to the recording of this very episode, which will be available both on Facebook as well as Twitter, as well as on medtalks.in. So it is very freely available. You can re listen to this discussion, and all of your these kind of problems and doubts will be cleared once you listen to our discussion again. Last but not the least, this is a very pertinent, very important question: what can we do for mental hygiene in elderly people, and any specific diets to be followed for these kind of people?
Thank you, Dr. Kantruji. I think this was kind of the showstopper question at the end. We all talk about physical hygiene. I think we have been very careful about physical hygiene post COVID. I always make it a point to stress on mental hygiene part of it as well. What can we do to keep our minds hygienic? Nothing very special, nothing very exotic. I think it's important that we understand that mental health is important. It starts with that. Charity begins at home. If we feel that our mental well being is challenged, our stress is probably crossing a line, it is important to share it with our social circles and seek professional help. If you know somebody who is facing these problems, and here is why this show becomes so important, please encourage him or her to seek professional help. There is no specific diet. It's important that, like in any other types of healthy diet that we discussed, it is important to cut down on carbs, on fat, probably have a balanced proportion of vegetables and fruits in your diet. Try to cut down on sugars and caffeinated drinks, empty calories as you age because the body processes it less. Have an active lifestyle. We all know that recently the Lancet Commission on Dementia has come up with a wonderful report that 40% of dementia risk can be reduced if lifestyle factors can be modified. So, cutting down on smoking, alcohol, at least an active exercise regime per day, digital detox. I think half of our lives is spent on screen now. So it's great to have a good walk with friends in the evening rather than WhatsApping them. And finally, at the end of the day, or in the beginning, or any time in the middle, even if you can find 15 minutes for yourself to do what you like, probably just hum to a favorite song, or probably look at your favorite music video, or talk to a friend whom you want, I think that me time becomes extremely important. We all have time for everything else in the world apart from ourselves. So if we can learn to do that, I think that solves half of the riddle. So stay well,
Right.
and I think it's very important that we take, especially if something that COVID has taught us is to take care of our mental hygiene besides the physical one.
डेफिनेटली वेरी वेरी वेल एक्सप्लेन्ड। डॉक्टर बैनर्जी बता रहे हैं कि हमें किस तरह अपनी मेंटल हेल्थ हाइजीन का ध्यान रखना चाहिए। ये जो मेंटल हेल्थ हाइजीन होती है, बहुत ही सिमिलर या बिल्कुल उसी तरीके की होती है जैसे हम अपनी फिजिकल हेल्थ का ख्याल रखते हैं। तो इसमें कोई स्पेशल डाइट्स नहीं होते हैं अलग से। आप अपनी डाइट में सब्जियों का सेवन और फ्रूट्स का सेवन बढ़ा दीजिए क्योंकि इनमें एंटीऑक्सीडेंट्स होते हैं और सभी रिपोर्ट्स में चाहे वो फिजिकल हेल्थ के लिए हो या मेंटल हेल्थ के लिए हो, एंटीऑक्सीडेंट्स बहुत ही महत्वपूर्ण काम करते हैं हमारी बॉडी को हेल्दी रखने के लिए। वहीं दूसरी तरफ यदि हम अपना जो वेट है वो एक हेल्दी रेंज में रखते हैं, तो सारी डिजीजेस को दूर रखा जा सकता है, जिसमें मस्कुलोस्केलेटल प्रॉब्लम्स भी आती हैं। तो मस्कुलोस्केलेटल आपने ये वर्ड आज के डिस्कशन में बहुत ज़्यादा सुना होगा क्योंकि एल्डरली लोगों की मेन प्रॉब्लम जो आती है वो पेन के कारण होती है या कम मोबिलिटी के कारण होती है। यदि आपका स्केलेटल सिस्टम स्ट्रांग होगा, ओल्ड एज में भी आप अपना वॉक कर पाएँगे, तो नथिंग लाइक दैट। आपकी जो मेंटल हेल्थ हाइजीन है, अपने आप मेंटेन हो जाएगी। वहीं दूसरी तरफ यदि आपको डायबिटीज़ है, तो शुगर का सेवन बंद कर दें, नमक कम खाएँ, अपने हाइपरटेंशन को कंट्रोल में रखें। सारी जितनी भी डिजीज़ेज़ आपको है या ऐसा लगता है कि आपको उसके होने का शक है, जाकर टेस्ट ज़रूर कराएँ। तो फिजिकल हेल्थ जो होती है, वो मेंटल हेल्थ से हमेशा रिलेटेड होती है। वहीं दूसरी तरफ अगर आपको लगता है कि आपकी मेंटल हेल्थ अफेक्टेड है, तो हिचकिचाए नहीं। किसी भी साइकियाट्रिस्ट से मिलके अपने जो डाउट्स हैं, उनको क्लियर करने की कोशिश करें क्योंकि यदि हम एक्सेप्ट करेंगे कि मेंटल हेल्थ प्रॉब्लम है, तभी हम उसके जो सॉल्यूशंस हैं, उसकी तरफ बढ़ेंगे। यदि हम ये सब चीज़ें इग्नोर करते हैं, तो पहले स्टेप के तरफ भी नहीं बढ़ पाते हैं। ये सब चीज़ों का ध्यान रखिए, अपनी खुशी का ख़्याल रखिए, अपने लिए 15-20 मिनट निकालिए और वो करिए जिसमें आपको आनंद आता है। I would like to thank you, Dr. Banerjee, for connecting to us today and sparing your valuable time with us. A very small token of appreciation from the team here in Med Talks from us, a small little certificate, which I would like to show you. We will be sending to you through email shortly. Thank you so much. Thank you so much, everyone, for connecting to us. And stay healthy, stay fit. Jai Hind.
Thank you so much. Take care. Bye bye.